And so, you know, that was just a super like big reality check. And I ended up dropping the class and was just like, I'm not gonna do this whole doctor thing at all. And I completely let, you know, being a doctor go. Hi guys, welcome to eShadowing. Hey everybody, let everybody get in. Before we start, filling up. Hi guys, I'm the guest and the host. I'm hosting and presenting today. So yeah, you'll have me. And if you've ever been in a session where I do a presentation, then it's just basically first a Q&A where I answer some of your questions, and then I present a case study. So it's similar to having a guest, except it's just focused on ER urgent care, something you'd see in ER urgent care. So we're gonna get started. We'll let people, whoever needs else is coming in, but we're gonna get started. So I'm Rodeline, I'm the guest for, I am your presenter for eShadowing. And I'm just gonna do a Q&A session today. So if you have questions, you can start asking your questions and you still get credit for being here. So yes, let me see if there's any questions yet. And before we start with the questions, this will actually be my last time on eShadowing, this eShadowing platform as far as me. So eShadowing with medical school headquarters will continue, but I will no longer be the host of eShadowing. I'll be moving to just doing eShadowing with MedSembly. So you guys can participate in both. With MedSembly, you do get credit. It's basically get the same type of credit. You'll get an hour credit for watching the sessions, but our replays will be in the app. So you'll be able to streamline and do everything in app. So you'll watch the sessions, and we track your activity in the app as well. So you know, to just ensure that you're actually watching it, because we go by the honor code as well. So you don't have to take a quiz or anything. But you know, if you say I watch, you know, 70 sessions, and you know, so that's 70 credits or 70 hours, but we only have you down as watching like, you know, 20 or whatever, you know, we have the system to track that. So that's what I mean. So you also have to take, you know, keep track of it manually, but I'm just saying we have a way to verify that. In terms of signing up, we'll send out a link to join eShadowing, and you'll just use the same link every week, just similar to this. It'll also be on Zoom. Yes, you'll receive the link to join eShadowing. Same process, but I wanted to create a better way to get the videos out to you guys, or the recordings out to you, the replays out to you guys, and so you always have access to it, whether, you know, even when you're a PA and when you're in PA school, because it's really informational and very valuable. So everything will be in app. And you can watch the recordings there too. So are there any other questions about eShadowing? You can still watch eShadowing on medical school headquarters. It's just that I will no longer be the host, and I'll just be on MedSembly. So you can watch both, just more ways to watch to get your hours. Alrighty. I'm sure all of you guys know what MedSembly is. MedSembly is a mentorship-driven app where students can connect with professionals and PA students, build relationships, get access to resources. It's really mentorship-driven community, and we help you also with your application assistance and yeah, shadowing opportunities, both in person and virtual. Really a resource, a career resource to get you started on your PA journey. Alrighty, now let's get to the questions. What is your job like? That's very broad. So my job is my job depends where I work. So I've created a lot of flexibility. I'm not your typical PA, guys. So that's why I have all these different guests. Oh, and just to also mention, not to forget, we're also going to do Ask Me Anything sessions on like IG Lives, and also put those recordings on the app where we have other guest PAs come on. But it's a little bit more fun and relaxed and not so much structure, because it's like Ask Me Anything. So if you have any question you want to ask a PA, they'll answer it live. So, but make sure you're following us on IG to, you know, find out when we do our Ask Me Anything and eShadowing. Wait, to everyone. Yes, so as I was saying, I'm not your typical PA. I am definitely I took a non-traditional route since becoming the past 2 years, I would say, or really, yeah, 2 years. So since creating MedSembly, or really taking off with MedSembly, I was working like more on my own schedule. I was working full-time, but more so like seasonal, I would say. Like sometimes I would work full-time, sometimes I would work part-time, but I would always be working. But now I'm just completely focused on MedSembly. So I'm not currently working as a PA. So that's what I mean by like, what do you do for work, or what does work look like? But I can tell you what work is like in the ER and in urgent care, because I just stopped in July. So since July, I would say. In terms of the ER, what it's like, it is very fast paced. I don't know if I should say, I can't say just about every ER has a staffing issue, but every ER I've worked at has a staffing issue, but that's only because the majority of ERs I've worked at has been while I was traveling, as I was a travel provider. And that's another thing, like I've had a few permanent jobs, but the majority of my jobs, or it feels like, have been like through travel work, or like kind of temporary-ish. And when you do travel work, when you're a locums assignment, it's to relieve that ER, a temporary relief. So say that someone goes on vacation or something, or not vacation, a maternity leave, like a provider is out, or leave of absence or whatever, or they're just short staffed. They just don't have the staffing, but it's usually due to a staffing issue that they hire locums. Locums is for temporary. Sometimes you might end up becoming permanent if they really need you, or if they really like you. But you're there because they need the staff. So I always run into the, understaff issue, and kind of having a heavy load of patients, where a lot of times it's, could just be me and the doctor. Like the where I last worked, sometimes it was just the doctor and I, and it would get really stressful. So be ready for that. If you choose to do like locums, or choose to work in certain areas like rural hospitals, you might be rural or critical access hospitals. There are certain hospitals and ERs where you could be the only provider. Like these are super rural areas, and the acuity may be low, but you just never know what's going to come into the ER. So it doesn't mean that you'll always have low acuity patients, but you're prepped, you're trained, you're going to be there by yourself. So everything's on you. I would say to do something like that after years and years of experience, where you're comfortable. But typically just you're gonna be with the doctor just in case you have questions, which you always will, or an issue arises. So you'll work with the team. Smaller ERs, it may just be you and the doctor. Larger ERs, of course, there's gonna be several APPs. APPs are advanced practice providers, which are nurse practitioners and PAs. And then of course your supervising physician, or the attending physician, another word for it. And yeah, and you're just gonna basically pick up patients, see patients. I have a case study, so you'll kind of get an idea of how it goes, but you'll see patients, or you'll have your tracker board. Actually, you'll sit in front of the computer, have your tracker. Your tracker shows all the patients that are in the ER. And they can base it based on the section in the ER and the rooms, and all of that can be based on like how sick the patient is, so the patient's level of acuity. But every ER is different. So then you'll pick up a patient from the tracker. You can pick up multiple at once, whoever needs to be seen. If you're new to the ER, then I say just one at a time. You'll pick up a patient, go see that patient, you'll do your history, you'll do your physical. And do you guys know what I always say when you see a patient in the ER, or when you evaluate ER patients? You guys know what I usually say in terms of evaluating ER patients? Just the evaluation part. And by evaluation, I mean like your history and physical. Anybody know the answer to this? How to evaluate them, or the method? When evaluating? Any responses? Okay, so I guess I'll answer since there's no responses. So the method for evaluating is you're going to do focus history and a focus physical. Focus means just that. Focusing on, what the problem is or what you believe the problem is to be in their chief complaint, to help you narrow down and get to your differential diagnosis. So for instance, if a patient comes in with abdominal pain, you're not really going to do a neural exam unless you think it could be related. If a patient comes in with an ankle sprain, you're not going to do an abdominal exam, right? You're going to ask some questions related to that ankle sprain, or that ankle injury. You're going to ask them questions related to their abdominal pain. You're going to ask them questions related to their headache. You're not going to say, oh, you're having a headache. Do you have any abdominal pain? I mean, you might just kind of knock some ROS stuff, review of system stuff, but you know what I mean? Are you guys understanding that you're going to ask relevant information? Or else you're just kind of going to be all over the place. And ER, as I said, is fast paced. You're going to have a lot of patients at once. You want to be efficient. And you want to be fast but efficient, but at the same time take your time. So how was PA school like? All right, PA school was and I feel like I'm getting to, I'm not too far removed from PA school. I feel like I'm definitely removed from CASPA. I'm not the best for CASPA questions. CASPA, I know I'm not answering the question yet, but CASPA was like 8 years ago, so PA school was 6 to 8 years ago, or CASPA was not 2013. Wow, it's actually 9 years ago. And then I started PA school the year after, 2014. PA school was, my opinion, it honestly wasn't too bad in terms of the material. Like the content wasn't terrible in terms of like just being difficult to understand the content. Like you read the content and you study, like you can kind of understand it. The thing with PA school is that you had so much at once and you only have such a limited amount of time to learn this information. Sure, I mean, I guess that's with anything. Like if you have, something, you're capable of learning it. It's just how quick can you learn it? That's the thing with PA school. How quick can you learn it, and how quick can you learn it, and how much can you learn? Are you able to take in all that information and then apply it to a patient, to your test, to pass? So that was the why people have a hard time with PA school. I would say that, don't quote me, don't come after me if you find this not to be true. In my opinion, PA school is definitely easier than like organic chemistry, like in terms of just being able to like material that's understandable. I feel like, sometimes you can read organic chemistry all day, every day, and you still don't get it. But like anatomy, or not even anatomy, diabetes, when you read it enough, when you study it enough, when you apply it enough, it starts to make sense, But organic chemistry, like some of those other classes, no. That's my take on PA school in terms of the content, is just having so much to study at once. So like you'll have 5 exams to study at the same time. So it's really about managing your studies well, time management, getting down a good study habit. Yeah. I would get a calendar. I would get a you know, your Quizlets, whatever study method works for you. And I always say this in my eShadowing sessions is the rule of threes. People say it works for them. So it worked for me is studying everything 3 times, and yeah, and then applying it like 3 times, like practicing 3 times. So I would study the PowerPoint 3 times, like keep going over the PowerPoint. I would then study actual notes, like paper notes 3 times. And then I would like create my own Quizlets and study the Quizlets 3 times. So it worked for me. So that was didactic. And that was fine. Like I said, I passed just all of my exams. And this is not to brag. But then again, I studied all day, every day too. Like I didn't really have a life. But then I kind of studied, I was a procrastinator too. But it's just that when it was time to study, I got down to business. But take your studies seriously in PA school. So yeah, there was just so much to study for. Like it was very easy to feel overwhelmed because you had so much to do. Like I would literally go through the PowerPoints, like skim through the PowerPoints as soon as I opened them to get an idea of how much studying I'd be doing. Like a PowerPoint that was like 150 slides, I'd just be over it already. And I'm just already on slide 1. I probably should not have done that to myself, but you know, it was so much. So yeah, and then of course, clinical year is a lot more relaxing. You're not so stressed with school. You just kind of have to pass your end of rotation exams and your OSCEs that you do, your practicums. And let's see, I think all schools do this, don't quote me, but you take this thing called the PAC-RAT. The PAC-RAT basically assesses your performance and your readiness to get into clinicals and then to pass the PANS. So you'll take the PAC-RAT before you start clinicals, and it's just a summary of your whole didactic year. And you'll see how you do. And then you'll do your clinicals, and then you'll take the PAC-RAT again. And then and the point of taking it again is, of course, because you want to see improvement, because you've done the clinicals and you've been able to apply it and see what you're learning in real life. So you're supposed to do better. And then the second time you take it, it's supposed to be a predictor of how well you will do on the PANS. So if you fail the PAC-RAT, chances are, there might be a chance that you fail the PANS. If you do really well on the PAC-RAT, you'll do really well on the PANS, and et cetera, et cetera. So, I mean, I passed the PAC-RAT. Yeah, let me see. I don't know if you guys have more specific questions, but that's about it. Why did you choose to become a PA? Why did I choose to become a PA? I chose to become a PA. I've told this story before. I was just really, really lost in terms of what I wanted to do for, my life. And just to kind of give you guys a rundown, I was initially pre-med, like all of us. And when people go from being pre-med to pre-PA, I don't think it's necessarily because they couldn't get into medical school, or they were failing classes or whatever. I didn't know about PA. I think a lot of us just didn't know about PA. And then so we're like kind of figuring things out, and then we land on PA, or we hear about it. But that's just because PA is a new career still compared to like doctors and nurses. So I switched my major. This was like freshman year, the first semester, no, really the second semester. I did good the first semester. It was summer and I took easy classes, but then actual fall semester started, and that's when the real work was, and I couldn't pass my pre-calculus class. And so I just tried everything. I just couldn't, I don't know. I couldn't pass it. I thought I did well and I got a C on the test. And I was like on the verge of getting a D in the class. And that was like unheard of for me, because I was a perfectionist in high school. Like I got straight A's, and so I'm a freshman going into college, like, oh, I'm gonna kill it in college. I'm gonna get into the best medical school. That's just my mindset, so naive. And here I am, I can't even pass this class. And so, that was just a super like big reality check. And I ended up dropping the class and was just like, I'm not gonna do this whole doctor thing at all. And I completely let, being a doctor go. And it took a really big toll on me. Just, I mean, more so like of what, like, my family would think, my parents, everybody, I was the first in my family, like in my immediate family, to go to college. I would be the first to become a doctor. So and then just me too, like feeling like I failed and gave up. And this was like all of college. Like I didn't figure out what I wanted to do until, or that it was PA until my senior year. And this was after trying nursing, didn't get into nursing school. I got waitlisted at UF. I got FSU just said, we don't want you. But at the same time, I didn't really put my all into nursing. I was just like, okay, I'm gonna try this. I just was kind of just trying stuff. There was no true passion behind it, I would say, because I was feeling so defeated and lost. So then I switched to sociology, like the easiest major. I'm just like, I'm gonna just do this. So I did that, and I was like, maybe I can, become a psychologist, a therapist, something. And I was gonna like just go to school and get my PhD or something. And then I studied abroad my senior year in college. I was still lost on what I wanted to do. And after studying abroad, I was just sitting one day. I worked as an LPN. I worked as an LPN at a nursing home. That's how I was able to just get my patient care hours. And this was before I knew about PA. I was able to work as an LPN because I went to my high school. I was able to get my LPN from high school. And so I was just sitting at work one day, and I saw PA, the name PA, and or the word PA, and I searched it, and I was like, okay, I can do this, this, and this, and I can become a PA, and I have this, this, and this already. And it just attracted me like to the profession. And I, started doing all my research, like what all of you guys do. And I was like, okay, this is definitely something that I feel like I can do. And, as I did more research, as I shadowed a PA, I really grew to like it. And that's how we got to where we are. How would you approach finding a PA to shadow in person with COVID protocols still in place? And that is crazy. So I hope I'm answering you guys' question. So somebody said finding a PA to shadow with COVID protocol still in place. So PA to shadow. With COVID protocols, I've actually been reaching out to PAs to see if they'd be open to shadowing. I have some that have said yes. And what I'm also doing, like me, is calling facilities to get shadowing opportunities for you guys from the app. Like, so they'll sign up on the app. So you guys can keep checking the app as well. But I literally have a list of like facilities I need to start calling and going to get it. So it's gonna be, I feel like it's gonna be a lot easier to approach like facilities, like medical facilities or clinics, as opposed to hospitals, because hospitals have more barriers. And there's a lot more patients in hospitals, it's a higher risk. So I wouldn't start with hospitals yet. I would start with like clinics, like small clinics or mom and pop clinics, or urgent cares. I'm not sure if urgent cares would be open to it, but I would definitely do clinics. And just reach out to them. Like, I think it's just kind of going to be the same technique that I had to do, which was just keep calling them until somebody says yes. But as I said, I am trying to get them more on the app. If you go on the app, you can swipe through and see shadowing opportunities in your area. And yeah, you'll see it from there. But I'm trying to literally go and add more. And I'm actually doing it by location. So I'm doing it by the 6 main locations right now, which is, or states, which is Georgia, Florida, New York, California, Michigan, and Texas. So those states are the states where a lot of our users, MedSembly users, are located, and the states that I'm focusing on right now. And once I get those states, and of course I'll get all the other states, but and that's also because the students vote. The students vote and tell me where they need shadowing. And so I work on getting shadowing for them from those states. In Ohio. So right now we have quite a few shadowing, I believe, in California. Like, I don't know where in California, like all my Southern, I believe, but we have some stuff in the works. Okay, so you just gotta keep checking the app, honestly. So we got some stuff in the works that I'm really excited and proud of. You know, y'all will see, especially in California and some other states. So I reach out to, you know, a lot of people for you guys. So I do this all day, every day. Okay, for PA school, what type of volunteering, research, shadowing, etc. did you do? So I would definitely say PA school is definitely a lot more competitive than what it was for me. I didn't do any research. I guess research is good, but I would prefer like work experience over research. I would prefer just me in terms of just being a medical provider, because like or patient care or working clinically. So I would prefer clinical work over like research, because clinical work is more hands-on. So you're going to be talking to patients and interacting with patients rather than research where you're, you know, kind of behind the scenes. I know for medical schools they're, you know, they're focused on research and whatnot, but so I only say that to say that, you know, you don't have to worry so much about doing everything. But if you do research or just naturally did research, then that's great. It's not like anything to not do. But I did do volunteering with Big Brothers Big Sisters. I did do my shadowing. I went to UF, so I was able to do UF shadowing with the PA, with the doctor that was a PA. That's funny. She was a PA. She went to PA school and then she went to medical school after. And then now she's a OBGYN, or back then she was an OBGYN. I'm sure she still is. And then, so I got some shadowing from her, and then I moved back to Fort Lauderdale and I got more shadowing. I only shadowed her for like 4 hours though. UF shadowing, not gonna say too much. I was gonna say UF shadowing kind of sucked. But I really got most of my shadowing on my own though. And I'm kind of finding that like when they do let you shadow, it's only for like, you know, a day or so. When I need a shadow for weeks, okay? So what I'm trying to do is really get contracts with these facilities. So there's gonna be consistent like shadowing. So if I can get that to make it work, then y'all gonna get y'all shadowing hours in person. Okay, just stay tuned. Stay tuned in Rodeline episodes of Rodeline Building Med Assembly. Okay, so yeah, and then as I said, I worked at a nursing home. I worked at a nursing home and a psych clinic or psych facility. The nursing home actually did psych there too, for my patient care hours. You mentioned that the person you shadowed did PA school, then medical school. It's basically this starting all over. So there's no like PA to MD, at least not that I know of. At least UF doesn't have it. So if you decided to be a PA and then you want to go and be a doctor, you have to basically go to medical school for 4 years. There's no like 2 years or anything, or PA to MD type of thing, bridge program. It's not like that. You basically start over. How do I get a job in the field for my patient care hours without any prior experience? Just got to keep looking. And that's another thing I'm working on too. So I do have some people. I think I have a connection in Georgia for patient care hours, but I have some surveys. You guys just gotta you guys have to I have a survey as well to find out where you need patient care hours. So if you let me know something, then I'm gonna try to get it for you. So I know you guys need patient care hours. You need your, you know, shadowing. So if you go on our Instagram and go in the link in our bio, we ask you questions on the different things you need, and we ask it for a reason, so we can know what to prioritize and focus on. And as we grow, then we're able to, you know, make things happen for you guys. If a PA wants to become a doctor later on in life, how long will it take? Yeah, it'll take 4 years. It'll take the same, just like you're starting all over. Okay, so it's 7:30. I'm gonna go ahead and do the case study. I'll share my screen and present the case study to you guys. And then if we have time for more questions, we'll do that. But if you guys go on my Instagram or Med Assembly's Instagram and go in the link in bio, you'll see the questions that we ask. We ask, where do you need shadowing? And we ask, where do you need a patient care job, or what patient care job you want? And we keep track of that because, based on, the areas that we need to focus on. So, and like I said, the responses have been Florida, Georgia, New York, California, Texas, Michigan. So those are the areas we're focusing on right now to get shadowing. So if you need in your specific area, we just DM me, DM or email us, and we're gonna make it work. But you guys got to give us some time. You got to give us some time. We trying to make it happen for you. All righty. Okay. Do you guys see my screen? All right, you should see my screen. If you don't, let me know. Okay, so this is an emergency medicine, but this can also be an urgent care case study. Does anybody know the difference between emergency medicine and urgent care? Does anyone want to come on and do the case study with me? Anybody want to come on to do the case study? If you want to come on and do the case study, you can raise your hand, or anybody want to come on? Y'all are shy. Okay. All righty. So does anybody want to, this is a great way to stand out and I'll remember you. Does anyone want to tell me the difference between the emergency medicine and urgent care, or the ER and urgent care? You can type it in the chat as well. I'll move on, but I'll be looking for that answer. Okay. So the ER, you always want to be thinking about ER, which is emergent cases, which is like life and death and things that you can't send a patient home with, because bad things can happen to them. You don't want to be liable for a patient's death or adverse reaction. So you always want to be thinking worst first with any patient that walks through the ER. It doesn't mean that that is what's going on. It just means that it's in the back of your head and you got to roll it out, or you got to ask the right questions to make sure that's not the case. You got to always be assessing if the patient is sick or not sick, if they need to be discharged, or if they need to be admitted, or if they can be discharged safely. You got to be thinking about your pearls and your differential diagnosis. And you always will have a team to consult and you're attending. ER is life or death situation, while urgent care is mild symptoms and not near death. Good job, Andrea. Urgent care is not necessarily mild, but they're more stable, and for the most part, they can go home. That's not always the case. So of course, you're gonna have urgent care patients that may need to be transferred to the ER, or that are unstable because they just walk into the urgent care. But if that's the case and you call an ambulance, or they can be transferred via privately owned vehicle if they're stable enough. But yes, you're right. Urgent care is not as emergent as the ER. It's urgent. All righty. So new arrival. A 19-year-old male presents to the ER. Wait, that's not the title of that one. It's something else. This one is like it's season, my bad. A 19-year-old male, and I want you guys to be interacting, because in real life, this is how you would have to be if you shadowed, right? You have to be interacting and answering questions. So I'm keeping track of that, because I'm noticing that people that are, you have to, you can't say you want to shadow in person if you just don't not participate, even virtual. So all right, a 19-year-old male presents to the ER with complaint of cough, runny nose, fever, body aches, and congestion times 2 days. So what's one of the first things you want to do when you read a patient's chief complaint? That is the chief complaint: cough, congestion, runny nose, fever, body aches, and congestion times 2 days. So what's one of the first things you want to do? It's on the screen. Check vitals. Yes, good job, Ibre. Good job. You want to check vitals. Good job. So yeah, so you want to check the patient's vitals. So this patient's vitals is here. So is this patient stable or unstable? Good job. Yes, this patient's stable. So this patient is 19. He doesn't have a fever. He's 86. His pulse is 86. Blood pressure is good at 116/74. Respiratory rate is 18. O2 sat is 99. Give me an example of a blood pressure that is unstable. What would an unstable blood pressure look like? Somebody said 143/93. Not exactly. That's pretty stable. 200/72. Okay, that's getting there. Yeah, in the ER, we don't treat blood pressure unless the patient's symptomatic. And some providers will treat it if it's like really, really high, of course. But yeah, we'll look at like 160/90 and we don't budge, we don't think anything. We worry a lot more about hypotension than hypertension for actually. So 80/50 could be concerning. I mean, of course, you don't want the blood pressure to be 200/72, but a lot of times people will go crazy when they see a blood pressure of 80/50 versus 200/72, especially if the patient already has high blood pressure. If they have high blood pressure and they're not symptomatic, a lot of providers don't treat. But if their blood pressure is 80/50, you got to do something. So, alrighty. So what should you be thinking about? What would you ask this patient? So this is you get this patient, and now you're gonna, as you're walking to this patient's room, you're gonna be thinking about, you're gonna be asking the patient, what may be in your differential. So that's why I ask these questions. All right, so now you're in the patient's room and you have to do your history and physical. You're gonna start with the history, of course, you're gonna ask questions before you touch the patient. So some of the questions you're going to ask is about their medical history, about their surgical history, family history, and social history. And of course, you're going to want to know more about their symptoms. So what would you ask about this guy's symptoms? He has cough, or just his presentation or his chief complaint: cough, congestion, runny nose, fever, body aches, congestion. We have when the symptoms started 2 days ago. What kind of cough? How long has it? We have that 2 days ago. How severe the symptoms are. Okay, like, does it keep you up at night? So what I would ask is, I'd walk in, introduce myself, and then I would say, what's going on today? And then he'll repeat, what's going on. And then he'll say he's had it for 2 days. And one of the first questions I'll ask is, has anyone else had these symptoms? Any known exposure to anything? Like, anyone been sick? Anyone have COVID? Have you traveled anywhere recently? And then I'll ask about, have you taken anything for the symptoms, like over-the-counter medications? Has anything helped you? Anything made it worse? And then I'll ask, so we got onset, we got anything helped, made it worse? Do you have any pain with this? Any headache, any abdominal pain? You can ask that, because there are some viruses that cause, systematic symptoms. So yeah, any headache, any abdominal pain. You can ask about how bad the cough is. Do you have any shortness of breath or chest pain with it? Are you coughing anything up? If you have a fever, he has fever, he said, but no fever here. And then if a patient complains of fever, headache, and neck pain, what should you be thinking? That's something serious in your differential. If a patient, so this patient has fever, but say he was to also have a neck pain and headache, what would you then be thinking about? Yes, good job, Sarah. I think I said that in another case study, but yes, or maybe she's just smart then. She's just smart. But headache, fever, and neck pain or knuckle rigidity are like classic symptoms of meningitis, which you don't want to miss. So they can present as a upper respiratory infection or just like a cold or virus or something. And some meningitis can be viruses, but you still just don't want to miss the meningitis because it can be fatal. I just always remember the fungal meningitis. Yes, that fungal meningitis, man. Okay. So I think we asked, oh, sorry guys. I think we asked just about everything for this case. We asked, he's been taking over the counter medicine, it hasn't really worked. He doesn't have, he said some people at his job have been sick. He doesn't know if they have COVID. Let's see, any medical problems? He doesn't have any medical problems, no history of surgeries. He doesn't smoke, he drinks occasionally, no family history. So let's go, now physical. So what are you gonna do for the physical? He has no other symptoms. What are you gonna do for your physical? Remember what I said about the history and the physical. So what would you do now? What would you do for the physical? Check airway, good. Well, you're not gonna do labs and COVID testing for your physical. Physical is you actually assessing the patient. Listen to heart and lungs, good job. So if the patient's having like cough and cold symptoms, I would check their ears as well. I would do like a HEENT, a hint exam, which is head, eyes, ears, nose, throat. So I would check their ears, I would check their throat, lymph nodes, good job. Yeah, make sure there's no knuckle rigidity, especially if they say they had a headache, neck pain, and fever. Yeah, so you'll do a hint exam or hint, whatever, hint, head, eyes, ears, nose, throat. You don't have to do too much with the eyes unless you think conjunctivitis or eye injury or whatever for like upper respiratory stuff. But make sure you check the throat, make sure you check the ears, especially too, with lymph nodes. And then always listen to the heart and lungs. You want to make sure they're breathing's fine. That's basically it. So, I mean, if they say they have abdominal pain, you can touch the belly. But, and then with kids though, I'll always touch the belly because a lot of times with kids, their symptoms present differently. So I'll always do an abdominal exam too with my kids if I think they have a URI or they have URI symptoms. All right, now we're gonna move on to the labs and tests. So you guys see how it's like a systematic approach. So you're gonna do their history, you're gonna do your physical, well, before that, you're gonna get your patient, you're gonna see their chief complaint, you're gonna look at their vitals, you can look at their past history if you have access to that. Then you're gonna do your history, you're gonna do your physical. Then based on that information you got from your history and physical, then you're gonna order labs and medicate and do all that other stuff because you gotta knock one out before you do the other. You can't give, order labs. I mean, sometimes you actually can order labs before seeing the patient if you want to start like if it's really busy and you want to start what you call it, forgot the term for it, but anyway, it's nothing that you guys need to know right now. Screening patients, that's the word. Okay, so what labs do you want to order for this patient? What labs do you want to order? Somebody said CBC, CMP. So every time you order something, whenever you order something, you want an indication for it, right? Whenever you do anything, you want a reason for why you're doing it. So what is your reason for doing a CBC and a CMP? What is that going to tell you? Based on the patient's symptoms. And it can be based on also a lot of things too, based on really all your findings so far. You got to tell, whoever why you do something. So say, you get dinged for it, like the doctor reviews your chart and says, why did you order a CBC on this patient with a cough and a cold-like symptoms? So you got to just be ready to explain it. Potassium, sodium levels, blood count. Okay, so we'll talk about that. So, does this patient need imaging? And if so, what imaging? No, I see a lot of no's. Okay, that answer is a yes or a no. So if you listen to the patient and he sounded bad, sure. If the patient says he's short of breath, he's having chest pain, he's having a bad cough, he's, all this stuff, the cough is bothering him at night, like it's the worst cough, yes. If it's just a mild, like if it just seems like, just regular cold symptoms, just a regular virus, then you don't have to. So it's really up to you whether you do a chest x-ray or not. And actually, so if it was an elderly patient, that had a lot of medical problems, I would always do that. Like I would probably do a chest x-ray on anybody over 40 that comes in with cold symptoms, just to make sure, and also depending on how long they had it too. If anybody over 60, I'll do a chest x-ray if they come in with like cough, especially if it's a bad cough, just to make sure it's not a pneumonia. So definitely the elderly, I'm more, open and more lenient with, doing chest x-rays on them, because they're so, they're more prone to like developing pneumonia and complications. So, but if he's a 19-year-old male, he's otherwise healthy, he probably just has a cold, he probably doesn't need a chest x-ray and expose him to that radiation, right? That's really based on your decision making and like the patient's presentation, the patient's age, the patient's symptoms, how comfortable you feel, if you're okay with not doing it, if you don't think he needs it. But say we did it, it was normal. Okay, so okay, so this patient basically, okay, let's go back. So we talked about the workup. So Alexis said so good job, Alexis. So she said COVID, strep, flu. So this is basically all this patient needs. The patient is otherwise healthy. The patient's symptoms have only been there for 2 days. The patient's vitals are good. The patient is 19. The patient, there's a lot of things to support why you only just need this. So Jessica, that's a good response saying CBC and CMP, but in this patient's case, there's not really a reason to do so. You don't think that it's not really going to change your decision making that this patient just really has a virus that's going to, more than likely get better after a few days. So if it was an elderly patient, as I said, then yes, if the patient was looking really bad, the patient looked toxic, if the patient had a high fever, if the vitals were unstable, if this patient had like a lot of medical problems, if this patient like said, oh my gosh, I have such bad chest pain with this, if this patient, if EKG looked crazy, then yeah, we'll do, labs. But if this patient just says, I have a cough and he doesn't look sickly, his vitals are good, then you just do flu, rapid, strep, COVID, and that should cover you. So this patient basically has a URI or upper respiratory infection. So there's upper respiratory and lower respiratory infections. So upper respiratory is anything above the trachea, so to your larynx. Lower respiratory is past your trachea, or like tracheitis, bronchitis, pneumonia. Those are all like lower respiratory tract infections. So upper respiratory is gonna, anything that's upper respiratory related. So sinusitis, pharyngitis, laryngitis, rhinitis, which is like your common cold. So yeah, it just depends on where it's going on. So a lot of times you might just put upper respiratory tract infection in your diagnosis, but it can be just any of those. You can get specific and say this patient definitely has a sinusitis, this patient definitely has a pharyngitis. If you check their throat, if they have a sore throat, check their throat, it's red, tonsils are swollen, or it's has spots and whatever, they have the positive strep, then it's a pharyngitis or strep pharyngitis. If they lost their voice, it's very hoarse, laryngitis. So yeah, it just depends on where it's going on in the upper respiratory tract. Let's see if I miss anything. So just the same thing, pictures. And then, as I said, lower respiratory is going to be your bronchi, like bronchitis, pneumonia. All right, you guys understanding it? So as I basically said all of this already, so epiglottitis, remember I said emergent. So most of these are not life-threatening. You can go home. What's it call it? Peritonsillar abscess can be life-threatening, especially when it blocks the airway. So you want to make sure the patient doesn't have that. And epiglottitis can be life-threatening too. I mean, pharyngitis can be life-threatening. Very rare cases, especially anything that's blocking the airway is what you think of when you think of life-threatening when it comes to URIs. Blocking the airway or, meningitis type stuff. So, yes, so epiglottitis it's not as common due to the Hib vaccine, but your epiglottis just gets swollen and it can block your airway, and kids can get it, or kids are more prone to it, and because of airways can be life-threatening. Somebody raised their hand. I don't know how to do this raise your hand feature. It was Lori. Lori raised her hand. Do you have a question, Lori? Allowed to talk. You have a question? Okay. Oh no. Okay. Then okay, sorry, I thought somebody raised their hand. Okay. You guys understand this, right? Everything? Next one is treatment. So this is really hard. This is going to be really hard as a provider because everybody's going to want antibiotics for their cold, but you got to educate. I rarely try to give antibiotics unless they're super annoying or they're prone to pneumonia. So if they're elderly and I think that they may get a pneumonia, I'll give them a Z-Pak or Augmentin or Amoxicillin or whatever. But 80 to 90% of URIs, upper respiratory infections, strep is not one of them. Strep is a bacteria, but like pharyngitis, laryngitis, all of that, sinusitis are viral. They're due to viruses, not bacteria. Okay, you explain that to your patient, you educate your patient, you tell your patient an antibiotic is not going to treat this because it is a virus. You might say this until you turn blue, but the patient's still going to want an antibiotic because it worked the last time. But this is to know, this is going to be on any exam that you see. Definitely your what's it called? Pharmacology. This was on my pharmacology exam because I remember the 80%. I have good memory. I remember the 80%. So they asked me that on my pharmacology exam, knowing that 80% of viruses are viral, no antibiotics. And explain to them that the more antibiotics they use, they build resistance and they might not be as effective. Okay. URIs treatments. So because it's a virus, no antibiotics, you're going to do supportive care. Supportive care basically means treating the symptoms. So getting lots of rest, staying hydrated, and letting your body do, the work to just get better, fight the virus off, letting your immune system take over. And yeah, so rest, hydration, over-the-counter medications like Theraflu, all those things to help you get you feeling better, Tylenol, whatever works for you. I'm not really an over-the-counter type of person. What do I have? What I tried one time? I think Alka-Seltzer or Theraflu emergency. I don't know. I'm not really one of the, I don't stock up on all those. I kind of just take vitamin C and then and water. But anyway, it's not about me. So you basically tell the patient that, you're going to get lots of rest. You're going to stay hydrated, take your vitamin C. You can take your zinc, take over-the-counter medicine, whatever is going to help treat the symptoms. And it should get better. Get lots of rest, stay hydrated. Don't be in bed all day, every day now. But yeah, and if you don't get better, you're always going to give precautions too, though. Excuse me. If you don't get better, if you're getting worse, then of course come back in. When to admit these type of patients: if they have a pneumonia, if they appear septic, if the vitals are unstable, if they're not getting any better, if they're dehydrated, if they just appear sick, and you'll see that and you'll have that thinking in your head that this patient is not well, like I cannot send this patient home. You'll build that intuition as a provider. All right, so that's about it. How do you know when a patient has sepsis? So sepsis is like a bad complication of being sick, of having an infection. So you'll know because their vitals will be unstable, they'll look sick, and you'll do certain tests like their lactic acid, you'll do blood work, and it'll be high, coupled with their vitals and their appearance. Like they'll look septic. So sepsis is when they're hypotensive, they have a fever, or they might have a low temp. They usually a lot of one of the two key signs, a lot of them is like high, fever and tachycardia. Like, and a lot of times these hospital charts, these charting systems, if they notice those two, it'll like do a little alert, and it doesn't mean that the patient's septic. It just kind of alerts you because to take note of these vitals that are a little off. And it could just be like, if you go running and exercising, you'll probably be hot and your heart rate will be fast. It doesn't mean you're septic. It just means that just happened. So you're in SIRS. But sepsis is, you'll have that, but you'll actually be sick. So look out for those unstable vitals. And then of course, an infection that's causing that. So you're septic. So you'll learn about sepsis. And unstable vitals, as I said, and if they appear dehydration, as I said, they just don't look well. So this is it, that's it. So just know what's common. And I always put this, my little pearls, but you don't really have to know everything. Things will come to you as you get experience and as you get to feeling comfortable. I wouldn't even focus on, know what's common, know zebras, know what can kill you. I'll focus more on of course, yeah, know what can kill you, know all that, but document like your life depended on it, because it does, and the patient's life. And you want to make sure you dot your I's, cross your T's, and you want to make sure you did a good job. Yeah, this is my contact information and how to reach me, and that's it. Stop share. Oh, we're right on time. Are there any questions? Or any questions, concerns? I guess like people just, we were off last week because of a holiday. People just forgot about eShadowing, since we had no eShadowing last week. But yes, guys, so this is, well, actually today is not my last day doing eShadowing. My last day is the end of September, so starting October 1st I'll be just doing it with MedSembly. So yeah, but you can still watch with eShadowing.com. Yeah, any other questions? Do you have to know information before shadowing? No. What do you mean shadowing? No, you don't have to know information, nothing in particular. So there's 2 more eShadowing sessions where I will host. We have a session next week, the 19th, and we have a session the 26th. And then after that, you won't see me any longer. How do we rewatch past eShadowing? That's the thing. So you can rewatch past sessions on YouTube. There's been difficulties with getting the past sessions on YouTube, so that's why I'm now doing them on the eShadowing YouTube. You can watch the ones that they have up, but there's been some difficulties with getting those up. So that's why I'm gonna do them on MedSembly, and then with, when we do them, we'll have them up, the next day or that night. So we'll have them on the app like as soon as possible. So yeah, but still watch with eShadowing.com and everything. Yes, we'll post our YouTube and everything that like before October 1st, because that's when it starts. So yeah, thank you guys. Thank you so much. Have a great night. See you next Monday. There will be a guest next Monday and the Monday after. Thank you. Bye.